Hi, my name is Rachel Davidson, and today we'll be discussing the migraine headache. Let's get into it. So first off, what is a migraine headache? It is more than just a bad headache. It ranges from person to person by severity and symptoms, but generally, in a very vague sense, they're classified into two different diagnoses, either a migraine without aura, and this is going to be your characteristic migraine that has an onset that's gradual to increasing in severity, usually unilateral. It can last from hours to days, and symptoms are nausea, vomiting, sensitivity to light, smell, sounds. You might experience mood changes or fatigue, but we'll go over this more. Or migraine with aura, which is essentially the same thing in addition to the onset of an aura, which could occur anywhere from 10 minutes prior to a migraine or an hour. And this is going to have your visual changes, flashing lights, zigzags, dots, sparks, however the patient might describe them. Could change in your alterations in your speech. You might experience numbness and tingling or confusion. Starting off with some signs and symptoms to look out for that are characteristic of a migraine. Starting off, we're going to have throbbing pain in the head. This is typically unilateral, but doesn't have to be. As you can see in the diagram there, it's kind of that central behind the eye unilateral pain. You might be experiencing nausea, vomiting, photophobia, meaning sensitivity to light, phonophobia, sensitivity to sounds, and in 25% of cases, roughly, they experience an aura, which we described as those visual disturbances like flashing lights, zigzag lines, and could include numbness or speech disturbances as well. A migraine can consist of these four phases, but may not include the aura in all patients. Starting off as a prodrome. Patients with migraines typically have this sensation a few hours to a few days before the headache occurs. Symptoms of this may include food cravings, unexplained mood changes, uncontrolled yawning, fluid retention, or increased urination. After this, they might get the onset of an aura. 25% of patients, I said, kind of experience this. And this is that visual disturbances, flashing lights, and again, this can occur 10 minutes prior, up to an hour prior to that headache sensation. Next is the headache. It's typically unilateral, it starts gradually and gets more intense as it goes on. Lastly is the postdrome. This is that feeling of exhaustion or confusion after a migraine period. Patients sometimes experience dizziness, difficulty concentrating, or mood changes. So what's happening in our body to cause this migraine? A trigger is going to start this off, and we'll dive deep into triggers later on, but a couple of them could be stress, a loud environment, hormonal changes, and this is going to offset a chain reaction in the brain. This is causing the brain to become overactive and causes the nerves to send more signals than necessary, known as primary neuronal dysfunction. Now there's this wave of brain activity spreading, and this is called cortical spreading depression, which is going to depolarize the glia and neurons across the cortex, and this can contribute to some of the symptoms we see in an aura, but it also can contribute to this inflammation in the brain. The wave is going to activate the trigeminal nerve to release chemicals and peptides that stimulate the blood vessels, causing the brain to swell and inflame, inducing that throbbing pain. As a result, vasodilation occurs, or the widening of vessels, which is causing the sensitization of our brain to be more sensitive to pain and stimuli. The diagnosis for a migraine is actually done strictly clinically. So the criteria is repeated attacks of a headache lasting from 4 to 72 hours with a normal exam and no other known cause for the headaches. The patient must report two of the following symptoms, either unilateral pain, throbbing pain, aggravated by activity, or moderate to severe intensity headache, in addition to nausea and vomiting, or photophobia or phonophobia. So that's the diagnostic criteria, but part of the assessment to make sure you have a normal exam is going to entail a detailed review of your past medical history, how old you are, your gender, profession, any surgeries, family history of migraine, are you using any estrogen birth controls, dietary habits, alcohol use. In addition to a physical and neurological exam of your symptoms, we want to know the onset, location, quality. We might ask you to keep a headache journal to better diagnose your symptoms. This entails logging your symptoms, the intensity of your migraine, what you did before it happened, maybe what you ate that day, to get a better sense of what's causing or triggering these migraines. And lastly, neuroimaging like an MRI or CT may be considered if red flag symptoms are present. Lifestyle and preventative management, what can we do? We can identify and avoid triggers. So I listed some of the triggers up here, but they can include fluctuations in temperature, changes in stimuli. It could include a minor head trauma or hormonal changes where women on their ovulatory cycle or menstrual cycle could experience migraines then. It's best to log our symptoms and track when we're having a migraine and what we did that day to help identify triggers and avoid them in the future. I've listed some of the common food triggers above, but if you're noticing that a food is a common trigger for you to get a migraine, it's best to avoid and manage this through dietary changes. Stress is a big trigger for a lot of people and very difficult to manage, but we can try to manage it through exercise, meditation, yoga, breath work, massage, or acupuncture have been found to be beneficial as well. Cognitive behavioral therapy is beneficial for controlling pain as well as managing emotional triggers. Managing active attacks can be beneficial to rest and sleep in a dark room, maintain adequate hydration, cool therapy. Waking up and going to bed at consistent times is also found to be beneficial, and supplementing with vitamin B2, magnesium, coenzyme Q10, and butterbur, which is a medicinal herb, is also found to be beneficial at controlling migraines. One kind of pharmacologic management is abortive treatment, and this is most effective when taken as soon as the migraine starts. It's more effective in a larger single dose than repeated, more frequent dosing of these medications that can lead to a rebound headache. So medications we commonly use for mild migraines are your over-the-counter NSAIDs like naproxen, aspirin, Tylenol, and then your triptans that we can take to kind of block the release of chemicals and block the pain pathways. For moderate migraines, we're going to try the mild pharm agents first, and if these aren't working, we might add in combination agent. This could be like sumatriptan and naproxen, for example, or we might add in an antiemetic like metoclopramide. We might give 10 milligrams by mouth if they're having nausea, vomiting symptoms. And then for severe migraines, we're going to be sending out to the emergency room. They're going to be needing IV or IM medications and antiemetics for this attack. If someone is having recurring or chronic migraines, we may consider preventative treatment. The first-line agents with the highest efficacy are going to be our beta blockers, tricyclic antidepressants, valproate or topiramate. Ones that have lower efficacy might be your calcium channel blockers like verapamil, NSAIDs, or SSRIs. Beta blockers is going to be our first line and most effective. You're starting on a lower dose, like 10 to 20 milligrams, taking 2 to 3 times a day, and we can titrate this up to 240 milligrams per day if necessary. We do want to avoid this in someone who has Raynaud's phenomenon though. Something we can use in a patient with Raynaud's is a calcium channel blocker, which also has an effect on aura symptoms. There is a risk of tolerance with this medication, so that's why it's not a first line, but we'll start at 80 milligrams and titrate up as well. Education and prevention for migraines. So we want to seek emergency room care for these red flag symptoms. Sudden onset of the worst headache of your life, a thunderclap headache, that rapid, intense, severe headache, neurological deficits like slurred speech, numbness and tingling that's prolonged, neck pain and stiffness with fever and vomiting or uncontrolled vomiting. We also talked about how trigger management is super important for prevention. So identifying those triggers and avoiding them will help manage these symptoms and the onset of your migraines in the future. This can include sleep hygiene, adequate hydration, stress reduction, dietary changes, or reducing your caffeine intake as well. So I encourage the use of a headache diary to log the symptoms, triggers, and identify any patterns to help manage this in the future. Follow up if your migraines or headaches persist despite abortive treatment, or if they're increasing in frequency or severity. And lastly, medications and management are to control, not cure migraines. I know that's a lot of information on migraines, so here are some additional resources to help further your understanding. The first is the American Migraine Foundation. They provide education, support, a Find a Doctor platform, resources like printable patient guides for people living with migraines. The National Headache Foundation also has a Living with Migraines tab, and they offer a series of informative videos for people living with migraines and headaches, addressing lifestyle management, triggers, treatment options, and more. The Association of Migraine Disorders also has patient resources like video explanations, blogs, podcasts, articles, and a migraine diary chart to help log those symptoms and identify your triggers. And that concludes our chat on migraines. Here are my references.